So let's go back to our baseball player trying to throw a 106-mile-an-hour fastball. And then go shut off one of the main muscles that stabilizes the scapula itself. So mental image, close your eyes. Close your eyes. Take a cannon, shooting a 106-mile-an-hour fastball. Young man, close your eyes. Now put that cannon in a canoe. Now fire it off. Now wake up. So, we have gross instability if we mess around with the muscles that stabilize the scapula, which is going to lead to some major issues with the shoulder. Major issues with the functioning of the glenohumeral joint and the motions that we get from them. So, muscles that we have on the scapula. Rhomboid minor, rhomboid major, levator scap, trapezius, serratus anterior, and one more guy who's not showing up in that view. Now one more guy is right there. From the distal tip of the scapula, we have the teres major. So frequently, as I've said before, if there's a longus, there's a brevis. If there's a medius, there's a lateral, lateralis or lateral version. We have a teres minor, which is in the rotator cuff muscle. We have a teres major as well. The seventh muscle is on the anterior surface and is pec minor. If I had pec major out of the way, then pec minor doesn't exist. So we'll go back to thorax. So pec minor is right here, and you can see how it inserts into that coracoid process, which is then going to help tip it forward. So muscle groupings. Rotator cuff. Which muscles are they? Supraspinatus, infraspinatus, teres minor, subscapularis. Good. So there's 4 muscles that are right there just by knowing your rotator cuff. Scapular stabilizers. Rhomboid minor, rhomboid major, trapezius. All 3 of those are on the medial border. We have levator scap, pulling up, elevating it. We have serratus anterior, opposing the rhomboids and the traps. We have teres major, which isn't as much of a scapular stabilizer because it's actually acting on the humerus. So I'm going to retract that and say it's not a scapular stabilizer. I apologize. The teres major is not a scapular stabilizer because it's acting on the humerus. I should have let that guy off. I apologize. So trap, rhomboid minor, rhomboid major, levator scap, serratus anterior, and pec minor. 6 muscles. So 4 rotator cuffs, 6 scapular stabilizers.
Teres major's off.
Teres major is a humeral motion.
Okay, so those are the stabilizers?
All right. Good run so far? Does this feel like it's more difficult or challenging at this point compared to lower hip evals or anything like that? It doesn't seem like it. Maybe yes? A little bit? There's a lot crammed into one space. So,
It's over there somewhere. Oh, it's right here. Did you pass?
all right. Where to now? So why is this tricky to people? Let's compare the the glenohumeral joint to the hip. What type of joints are they?
To the left?
Yes.
Ball and socket joints, both. Which one has more mobility?
Shoulder.
So I mean, hip can go here. It's about how far out in abduction can you get? Shoulder can go here, all the way back here. I'm going to go with shoulder on mobility. It wasn't meant to be a trick question. Which one has more stability?
Like
Your hip.
hip.
You take the head of the femur and you mostly wrap a bony acetabulum around it and it's stable. It becomes very difficult with forward flexion and abduction to ever dislocate that thing.
Yes.
So the socket itself is a very deep socket. The head is quite stable within it. And we have a whole lot of musculature that kind of anchors in place. When we get to the humerus, it's just not very fun. Skeletal, that's awful. I don't care what time of day it is, it's way too bad. So, if I take the humerus and I make him go away, and we get a window in there, that right there is called the glenoid. It's the articular surface of the scapula on which the head of the humerus articulates. It's like trying to take a huge ball on a dinner plate. So rather than wrapping around it like the acetabulum does around the head of the femur, this thing is pretty much just sitting there with the ball kind of articulating around a shallow groove. Now to increase the depth, you have the meniscus, the cartilage, which is kind of like a ring cup that goes around the outside. So it adds a little bit of a flexible depth to that glenoid cavity, which helps get an increase in range of motion. But at the same time, it's surprisingly, well maybe not surprisingly, but it's considerably more unstable. So we have all kinds of issues in terms of how the humeral head stays put in that place. Now the first anchoring point we have is the glenohumeral ligament, the joint capsule that goes around it. And again, we have the superior, middle, and inferior portions that help stabilize and reinforce that joint capsule to keep it from going anywhere. With this bony landmark back here, it's more difficult to push through and just be able to go backwards to cause damage. If I come forward here, it's fairly stable. Posterior dislocations are rare. But if I have a force that drives the humeral head forward, there's not a whole lot that's stabilizing and holding on to it. None of this is bony, it's all ligamentous. So it's quite possible to push that humeral head forward. Now if we do that once, we stretch the joint capsule, or we do motions that repeatedly over time stretch that joint capsule, we run the risk of having laxity there. Looseness, where the humeral head can slip out of position. So if it's not stable, or your mechanics and movement aren't stable, then we run into all kinds of other potential problems. So how do those other problems manifest? What are we looking at?